I'm Dr. Deepak Pava, and today we are into the second lecture of our series on regional anesthesia for upper limb surgeries. We have already covered the anatomy of the brachial plexus, the brachial plexus block at interscalene level, the supraclavicular level, and the infraclavicular level. The objectives of today's lecture include the brachial plexus block at axillary artery level, the individual nerve blocks. This includes phrenic nerve sparing shoulder blocks, which comprises of suprascapular and axillary nerve block, the nerve blocks at the level of elbow, and the individual nerve blocks at the level of wrist. Today, we'll be starting with brachial plexus block at axillary artery level. The indications for this block include surgery on the forearm, surgery on the wrist, or surgery on the hand. This includes surgeries that require application of tourniquet. The contraindications for this block are refusal by the patient, infection at the injection site, the enlargement of axillary lymph nodes, or any pre-existing neurological deficits in the ipsilateral upper limb. Brachial plexus block at axillary artery level blocks the plexus at the level of individual nerves. At the apex of axilla, the cords, they start forming the terminal nerves. The median, the ulnar, and the radial nerves, they accompany the axillary artery in the axilla, while the musculocutaneous and the axillary nerve, they leave the plexus at the level of coracoid process. Musculocutaneous nerve runs laterally and lies either in the belly of coracobrachialis or between the short head of biceps and coracobrachialis muscles. The median nerve lies superolateral to the axillary artery, while the ulnar nerve lies medial and inferior to the artery. Radial nerve lies inferior to the axillary artery. These relationships are important while we are giving landmark guided axillary brachial plexus block. For giving this block, the patient is placed supine with arm abducted and externally rotated at around 90 degrees. There are various techniques to give landmark guided axillary brachial plexus block. We'll start with the single injection technique. After positioning the patient, the axillary artery is palpated at the level of pectoral muscles. For surgeries over the lateral or dorsal aspect of upper limb, the needle is inserted inferior to the axillary artery so as to target the radial nerve, while for surgeries around the medial or palmar aspect, the needle is inserted superior to the artery so as to target the median nerve. After obtaining the desired motor response in the form of either extension of the fingers or wrist or flexion of the fingers and wrist, the needle is gradually advanced and the current strength, which was initially kept at around 1 to 1.5 milliampere, is gradually reduced to around 0.5 milliampere. When adequate twitches are obtained, the local anesthetic is injected after negative aspiration of blood. While giving this block, if there is flexion of elbow, this indicates stimulation of musculocutaneous nerve and tells us that needle is still away from the neurovascular sheath. We should then redirect the needle superficially and medially. For giving this block with the help of double injection technique, which is actually a better technique, the needle is first inserted above the pulsations between the axillary artery and the coracobrachialis muscle, looking for flexion of wrist or pronation, that is the response in median nerve territory. The needle is gradually advanced towards the nerve. Initially, the current strength is kept at around 1 milliampere, and then gradually it is reduced so as to obtain the response at around 0.5 milliampere. Once adequate response is achieved, 7 to 10 ml of local anesthetic is injected at that point. The needle is then withdrawn and redirected inferior to the arterial pulsations between the axillary artery and the triceps. Initially, again, the current strength is kept at around 1 to 1.5 milliampere till the desired response in the form of extension of either wrist or fingers is obtained. When adequate response is achieved, at around 1 to 1.5 milliampere. The current strength is gradually decreased and needle is advanced very slowly till adequate response is achieved at around 0.5 milliampere. Again, at this point, 10 ml of local anesthetic is injected after negative aspiration of blood. There is another technique, which is the multiple needle injection technique. The purpose of this technique is to target musculocutaneous nerve as well, which usually leaves the axillary artery at the level of coracoid process. So the technique is almost identical to the double injection technique. The difference is that after locating and injecting in the median nerve territory, the needle is withdrawn till it comes in and lies in the superficial plane. Then it is redirected obliquely in coracobrachialis muscle till the response of musculocutaneous nerve in the form of contraction of biceps, that is the flexion at elbow joint, is obtained and elicited at around 0.5 milliampere. Again, the needle is withdrawn and brought back to the subcutaneous plane, and needle is redirected inferior to the axillary artery so as to target the radial nerve. Again, around 10 ml of injected local anesthetic is injected around each nerve. While giving ultrasound guided axillary brachial plexus block, the patient is again kept supine with arm abducted at right angle. We should be careful as to not to over abduct the arm, as it causes stretch of the brachial plexus. The pectoralis major tendon is palpated as it inserts on the humerus. Linear high frequency transducer is placed just distal to the pectoralis tendon, perpendicular to the long axis of the arm. The biceps muscle, the coracobrachialis muscle, and the axillary artery, they are identified in the cross-sectional view. The median nerve, ulnar nerve, and radial nerve are then identified as hyperechoic round structures lying superficial and lateral, superficial and medial, and posterior and medial or lateral to the axillary artery. Musculocutaneous nerve is then identified as hypoechoic oval structure surrounded by a hyperechoic rim, which is lying in between biceps and coracobrachialis muscles or in the belly of either of these muscles. Musculocutaneous nerve can be reconfirmed by moving the probe proximally and distally. As the probe is moved proximally, musculocutaneous nerve can be seen joining the neurovascular bundle. The needle is then inserted in plane from lateral to medial direction and directed towards the posterior aspect of axillary artery. Target is to deposit local anesthetic around radial nerve. Around 7 to 8 ml of local anesthetic is deposited close to the radial nerve. The needle is then withdrawn till the subcutaneous plane and then redirected towards ulnar and then median nerve, and around 5 to 7 ml of local anesthetic is deposited around each nerve. The needle is again withdrawn till the subcutaneous plane is reached and then redirected towards the musculocutaneous nerve, which lies in between the coracobrachialis and biceps muscle or in the belly of either of these muscles. And again, around 5 ml of local anesthetic is deposited close to musculocutaneous nerve. A nerve stimulator can also be used to decrease the risk of inadvertent needle injury. For giving continuous axillary brachial plexus block, the technique is almost the same. The needle is advanced in plane till the posterior aspect of axillary artery is reached. The needle tip position is confirmed by injecting around 1 to 2 ml of saline. Catheter is then threaded for around 3 to 5 centimeters beyond the tip of the needle, and the needle is withdrawn. The position of the catheter is reconfirmed by injecting saline through the catheter. The catheter, after confirming the position of the catheter is then fixed to the skin using sterile adhesive tape. This finishes the axillary brachial plexus block. Now coming to the peripheral nerve blocks at the level of elbow. The indications of giving the nerve blocks at the level of elbow include surgery in the distal forearm that require the motor blockade. It can also be used to supplement incomplete proximal brachial plexus blockade. Now we'll start with the relevant anatomy. Radial nerve, it provides sensory innervation to the dorsum of hand and forearm, and motor innervation to the extensors of the hand. Radial nerve descends down the arm, crossing from medial to lateral side of humerus. At the level of epicondyle, it lies between the brachialis and the brachioradialis muscles, where it can be easily blocked. For giving this block, the patient is positioned supine with arm abducted and supinated. The biceps tendon is palpated at the level of epicondyles. A point is marked which is around 1.5 centimeter lateral to the biceps tendon. A needle is injected perpendicular to the skin at this point, just deep to the biceps tendon. A nerve stimulator is attached to the needle, and when wrist extension is elicited at around 0.5 milliampere current strength, that is our target point, and around 3 to 5 ml of local anesthetic is deposited at this point after negative aspiration of blood. For giving the radial nerve block at elbow level with the help of an ultrasound, patient is again positioned supine and with elbows flexed. The linear high frequency transducer is kept on the lateral aspect of arm just above the elbow. The nerve appears as a hyperechoic honeycomb structure which lies between the brachialis and the brachioradialis muscles. The position of the radial nerve can be reconfirmed by moving the transducer proximally. The radial nerve will be seen traveling posteriorly towards the humerus to lie in the radial groove below the triceps. After confirming the position of the radial nerve, needle is introduced in plane from lateral to medial direction. Once the tip reaches close to the radial nerve, 4 to 5 ml of local anesthetic can be deposited after negative aspiration of blood. Now coming to the median nerve block at the level of elbow. Median nerve, it provides sensory innervation to lateral 3.5 fingers and the lateral side of the palm. It also provides motor innervation to the flexors of the forearm. As it traverses down the humerus, it crosses the brachial artery and comes to lie medial to the brachial artery at the level of elbow. For landmark guided technique for giving median nerve block, the patient is placed supine with arm abducted and supinated. Pulsations of the brachial artery are felt at the level of epicondyle. Needle is inserted perpendicular to the skin, just medial to the brachial artery pulsations at this point. Again, a nerve stimulator is attached to the needle, and either flexion of the wrist or opposition of thumb is elicited at around 0.5 milliampere. And once the adequate contractions are achieved, 3 to 5 ml of drug is injected at this point. For giving median nerve block with the help of an ultrasound, the patient is again placed supine with arm abducted and hand in supination. A linear high frequency transducer is kept transversely in antecubital fossa. The pulsations of brachial artery are identified. The median nerve lies just medial to the artery at the level of elbow. A needle is introduced in plane from medial to lateral direction towards the nerve. Once the tip reaches close to the nerve, around 4 to 5 ml of local anesthetic is deposited close to the nerve. For giving an ulnar nerve block, we should first know about the relevant anatomy. Now, the ulnar nerve, it provides sensory innervation to medial 1.5 fingers and medial side of the palm. It also provides motor innervation to flexor carpi ulnaris, the medial half of flexor digitorum profundus, and the intrinsic muscles of hand and erector pollicis. At elbow, it is located in the ulnar groove, which lies posterior to the medial epicondyle. For giving a landmark guided ulnar nerve block, the patient is placed supine with arm abducted and forearm flexed and supinated. The medial epicondyle is palpated. The ulnar groove lies just posterior to the medial epicondyle. A needle is inserted in the ulnar groove perpendicular to the skin. A nerve stimulator is attached to the needle. Motor response in the form of either adduction of thumb finger flexion, and or ulnar deviation of the wrist is elicited at around 0.5 milliampere. Once adequate contractions are being elicited, 2 to 3 ml of local anesthetic is injected at this point. We should be careful not to inject higher volume at this point for giving an ulnar nerve block so as to prevent compressive neuropathy of the ulnar nerve. For giving ultrasound guided ulnar nerve block, the patient is again placed supine with arm abducted and hand in supination. A linear high frequency transducer is first kept in antecubital fossa and then gradually moved medially. Ulnar nerve is identified as a superficial hyperechoic honeycomb structure which is lying superficial to the triceps muscle and just below the brachial fascia. The needle is introduced in plane from lateral to medial direction towards the nerve. Once the needle tip lies next to the nerve, around 4 to 5 ml of local anesthetic is deposited close to the nerve. The complications of giving the block at the level of elbow include injury to the brachial artery while giving median nerve block, and one should be careful while giving an ulnar nerve block because there are chances of compressive neuropathy of the ulnar nerve if larger volume of local anesthetic is deposited in the ulnar groove. Now we'll discuss peripheral nerve blocks at the level of wrist. Well, the wrist block entails blocking ulnar, median, and radial nerves individually at the level of wrist. The indications for giving wrist block include surgeries on the hand and on the fingers. The advantage of giving a wrist block include that it prevents the motor blockade of the proximal arm. Coming to the relevant anatomy, the ulnar nerve provides cutaneous innervation to medial 1.5 fingers and corresponding area over the palm. It also provides innervation to medial 2 lumbricals, all the interossei and erector pollicis muscle. In the forearm, ulnar nerve, it travels deep to flexor carpi ulnaris and gives 3 branches. The muscular branch, it supplies the flexor carpi ulnaris and flexor digitorum profundus muscle. The medial half, the palmar cutaneous branch, it supplies the skin over the medial half of the palm, while the dorsal cutaneous branch, it supplies the skin over the dorsal surface of medial 1.5 fingers and corresponding area over the hand. Ulnar nerve, it passes superficial to flexor retinaculum and medial to ulnar artery at the level of wrist. In the hand, it divides into superficial and deep branches. The superficial branch supplies skin over medial 1.5 digits, while the deep branch, it provides motor innervation to medial 2 lumbricals, all the interossei, the erector pollicis muscle, the hypothenar muscles, and palmaris brevis muscle. For giving landmark guided ulnar nerve block, the needle is inserted just medial to the tendon of flexor carpi ulnaris near its attachment at the ulnar styloid process. The needle is inserted 5 to 10 millimeters so as to pass it just under the tendon. 3 to 5 ml of local anesthetic is injected at this point. While taking the needle out, another 2 to 3 ml of drug is injected in the subcutaneous plane to block the cutaneous branches of the ulnar nerve. For blocking the dorsal branch of ulnar nerve, the needle is inserted on the dorsal aspect of flexor carpi ulnaris muscle, directing it towards the radioulnar joint. 4 to 5 ml of drug is injected subcutaneously in this plane. When using ultrasound for giving ulnar nerve block, the patient is placed supine with the arm abducted and the forearm supinated. A linear transducer is kept around 5 to 10 centimeters proximal to the wrist. On the medial aspect, a pulsatile structure, that is ulnar artery, can be visualized, as we can see in this photograph. Ulnar nerve lies just medial to the ulnar artery or ulnar to the ulnar artery and can be seen as a hyperechoic structure which lies just next to the artery. It is typically blocked 3 to 4 inches proximal to the wrist crease, as palmar cutaneous branch, as we have discussed, leaves the main nerve at this location. The needle is introduced in plane from either direction and 3 to 5 ml of drug is deposited close to the nerve. Now coming to the median nerve block. The median nerve provides sensory innervation to lateral 3.5 fingers and lateral side of the palm. It also provides motor innervation to the flexors of forearm, the thenar muscles, and the lateral two lumbricals. In the forearm, median nerve passes between flexor digitorum superficialis and flexor digitorum profundus. It gives off anterior interosseous nerve in the proximal forearm, which supplies the deep muscles in the anterior forearm. In the distal forearm, it gives palmar cutaneous branch, which passes superficial to the flexor retinaculum and supplies the area of the palm corresponding to the lateral 3.5 digits. The median nerve then passes through the carpal tunnel below the flexor retinaculum and gives digital branches to lateral 3.5 digits and the lateral two lumbricals and the three thenar muscles. For giving landmark guided median nerve block at the level of wrist, we should identify the tendons of flexor carpi radialis and palmaris longus. The needle is inserted in between these two tendons. Advance the needle till it hits the bone. Withdraw the needle for around 2 to 3 millimeter and inject 3 to 5 ml of drug at this point. For giving ultrasound guided median nerve block at the level of wrist, again, this block is given at around 3 to 4 inches proximal to the wrist face, as palmar cutaneous branch can leave the median nerve at this point. The needle is introduced in plane from either side and 3 to 5 ml of drug is deposited close to the nerves. On ultrasound, median nerve lies very superficially at the level of wrist, beneath the flexor retinaculum and next to the tendons of flexor digitorum superficialis, flexor digitorum profundus, and flexor pollicis longus tendons. It can be confirmed by tracing it proximally towards the elbow. Here it can be seen passing deep to the flexor digitorum superficialis muscle and lying medial to the brachial artery at the level of elbow. It can also be confirmed at wrist due to its anisotropic nature on ultrasound. Here, by tilting the probe, it makes the nerve appear either hyperechoic or hypoechoic alternately. Now, the radial nerve block at the level of wrist. The radial nerve supplies the dorsum of the hand corresponding to lateral 3.5 fingers, the dorsal aspect of lateral 3.5 fingers except the area around the lane breadths. It also supplies the muscles of the posterior aspect of the forearm, which serve the function of extension of wrist and fingers and supination of the forearm. Radial nerve divides into superficial and deep branches at the lateral border of cubital fossa. The superficial branch passes down the lateral aspect of the forearm, lateral to the radial artery. At around 3 inches above the wrist, it passes laterally and posteriorly deep to the tendon of brachioradialis muscle. It pierces the deep fascia and continues into the hand to supply the posterolateral surface of the hand. The deep branch, it pierces the supinator muscle and continues as posterior interosseous nerve, which supplies the muscles of the posterior aspect of the forearm. For giving landmark guided radial nerve block, the radial styloid is palpated. A needle is inserted just proximal to the styloid. 5 ml of drug is injected in the subcutaneous plane while directing the needle first medially, and then another 5 ml of drug is injected in the same plane while directing the needle laterally. For blocking the dorsal sensory branch of radial nerve, needle is inserted 1 inch proximal to radial styloid and lateral to the radial artery. Around 5 ml of drug is injected in the subcutaneous plane at this level. Using ultrasound for giving radial nerve block at the level of wrist, the radial nerve is usually blocked at mid-forearm level, as the superficial branch of radial nerve divides into multiple branches at the level of wrist. Radial nerve lies radial to the radial artery, that is lateral to the radial artery at mid-forearm level. This we should always remember. So a needle is introduced in plane from either side and 3 to 5 ml of drug is deposited close to the nerve. Now coming to the last topic in our series, that is the phrenic nerve sparing shoulder block. The indications for giving phrenic nerve sparing shoulder block include arthroscopic shoulder procedures like subacromial decompression, the labral repair, the AC joint reconstruction. It can also be used in major open shoulder surgeries like rotator cuff repair, where interscalene block is contraindicated because of morbid obesity or significant respiratory compromise. This block, the phrenic nerve sparing shoulder block, should not be used in rotator cuff surgeries involving the subscapularis muscle, as subscapularis muscle is supplied by the subscapularis nerve and not by the suprascapular and the axillary nerve. First of all, we'll discuss the relevant anatomy. Shoulder joint is supplied by 5 nerves: the suprascapular nerve, the axillary nerve, the musculocutaneous nerve, the subscapular nerve, and the lateral pectoral nerves. Major part of the shoulder joint is supplied by 2 nerves, the suprascapular nerve and the axillary nerve. Coming to the innervation of shoulder joint, the suprascapular nerve, it supplies the superior, the medial, and the posterior aspect of the joint capsule, the glenoid, the acromion, the posterior surface of the scapula, and the AC joint. The axillary nerve, it supplies the anterior, the lateral, and the inferior aspect of the joint capsule, the head of the humerus, the proximal neck of the humerus, and the skin over the lateral part of the arm. The subscapular nerve, it supplies the anterior joint capsule, the anterior glenoid, and the anterior surface of the scapula. The lateral pectoral nerve, it supplies the anterior joint capsule, the pectoralis major and the pectoralis minor muscles. The musculocutaneous nerve, it supplies the anterior joint capsule and the long head of biceps in the glenohumeral joint. Now, the suprascapular nerve, it arises from the superior trunk. It passes posterolaterally below the inferior belly of omohyoid towards the suprascapular notch. It then enters the supraspinous fossa through the suprascapular notch below the transverse scapular ligament. Here it supplies the supraspinatus muscle and gives a branch which supplies the posterior aspect of the shoulder joint. The nerve then leaves the supraspinous fossa through the spinoglenoid notch and terminates by supplying the infraspinatus muscle. Now, coming to the axillary nerve, it arises at the terminal branch of the posterior cord formed at the lateral border of subscapularis. It runs towards the posterior aspect of the surgical neck of humerus through the quadrangular space. The quadrangular space is bound above by the teres minor muscle, below by the teres major muscle, medially by the long head of triceps, and laterally by the shaft of humerus. The axillary nerve is accompanied by circumflex humeral vessels in the quadrangular space. The axillary nerve supplies the deltoid, the teres minor, and it also provides sensory innervation to the lateral upper arm. For giving landmark guided suprascapular nerve block, the patient is placed in a sitting position. This nerve is blocked during its passage through the suprascapular notch to the spinoglenoid notch. The patient's hand is adducted by his side. The medial end of the spine of scapula and the lateral end of acromion, they are joined together by a line. The midpoint of this line is then identified, and a point is marked that is 2 centimeter medial and capillate to this point. A 10 centimeter insulated needle is then inserted at this point and directed laterally and caudally for around 4 to 6 centimeters. Stimulation of infraspinatus or supraspinatus is observed by initially setting the current strength at around 1 to 1.5 milliampere and then gradually reducing it so as to elicit the contractions at around 0.5 milliampere. Once adequate contractions are achieved at 0.5 milliampere, 10 to 15 ml of local anesthetic is deposited after negative aspiration of blood. For giving this block with the help of an ultrasound, the patient is again placed in sitting position. We can use either a low frequency curvilinear transducer or a high frequency linear transducer depending on the build of the patient. The transducer is kept horizontally over the spine of the scapula. A hyperechoic continuous shadow is cast by the spine of the scapula. The probe is then moved laterally. A sudden break or step in the continuity of the spine is seen. This indicates the formation of spinoglenoid notch. The suprascapular nerve and artery can be seen in the spinoglenoid notch. The pulsations of the artery can be appreciated at this level. The needle is introduced in plane from medial to lateral direction, directing it towards just medial to the spinoglenoid notch. When the needle reaches just medial to the spinoglenoid notch, around 10 ml of local anesthetic is deposited just below the supraspinatus muscle after negative aspiration of blood. It is not necessary for the needle to pierce the spinoglenoid notch. It is sufficient to place the tip of the needle just medial to the spinoglenoid notch. The complications of this block include injury to suprascapular vessels and hematoma formation. Pneumothorax can happen, especially if the needle is directed too much anteriorly. Now we'll discuss the axillary nerve block. For giving axillary nerve block with the help of landmarks, we again place the patient in a sitting position. The nerve is blocked at its passage through the quadrangular space, the anatomy of which was discussed a few slides back. A line is joined from the anterior acromion to the inferior angle of the scapula. The midpoint of this line is marked with a horizontal line. This represents the horizontal plane of the quadrangular space. The posterolateral aspect of acromion is then palpated. A line is drawn vertically down from this line, intersecting the previously drawn horizontal line. This is our point of insertion of the needle. A 10 centimeter insulated needle is then passed anteriorly from this point. As the needle passes 2 to 3 centimeters inside, twitches in the posterior deltoid can be seen. These are due to direct stimulation of the deltoid muscle as the needle passes through it. The needle is further pushed inside. Twitches in anterior deltoid can then be elicited at a depth of 6 to 8 centimeters. This indicates stimulation of axillary nerve, and at this point, 10 to 15 ml of local anesthetic is deposited once adequate contractions are achieved at 0.5 milliampere. If no twitches are elicited, redirect the needle either superiorly or inferiorly. We should be careful while redirecting the needle superiorly as it may enter the capsule of the shoulder joint. If no twitches are elicited even after redirecting the needle, we should deposit the local anesthetic at the initial insertion point just below the deltoid at the posterior aspect of humerus. While taking the help of ultrasound for giving axillary nerve block, the patient is again placed sitting. A linear high-frequency transducer is kept along the long axis of the humerus at mid-arm level. A linear hyperechoic shadow is cast by the shaft of humerus. This shadow is then traced upwards. This shadow is then traced upwards towards the head of the humerus when the humeral head can be seen. The probe is then again moved downwards towards the shaft of the humerus for around 0.5 to 1 centimeter, where the pulsations of circumflex humeral artery can be seen. The axillary nerve lies just next to the artery, deep to deltoid and between the teres minor and triceps muscles. 10 ml of local anesthetic is deposited at this point. The complications of giving axillary nerve block include injury to circumflex humeral vessels and hematoma formation. This concludes our lecture the second lecture of our series on regional anesthesia in upper limb surgeries. I hope you found it useful and beneficial. Thank you so much.